All right, and now I have the honor and pleasure of introducing Dr. Robert Thomas today. Dr. Thomas received his medical degree from Madras Medical College, India. He then completed his internal medicine residency and chief residency from Eastern Tennessee State University, and then his fellowship in neurology from Beth Israel Deaconess Medical Center in Boston. Dr. Thomas is a professor of medicine at Harvard Medical School and in the Division of Pulmonary Critical Care and Sleep Medicine at the Beth Israel Deaconess Medical Center in Boston. He's also an associate director of the Sleep Center and associate program director of the Sleep Medicine Fellowship Program. He's also the founding director of the Institute for Personalized Sleep Health at Beth Israel, which has the goal of rapid translation of best and latest science to patients. His research includes complex sleep breathing syndrome, signal science, and brain health in sleep disorders, and the foundational theme of his expertise is in the dimension of system stability and instability in sleep and sleep-disordered breathing. He's one of the foremost experts in sleep disordered breathing and was a pioneer in treatment emergent central apnea or complex sleep apnea. He's lectured in courses in sleep disorders nationally and internationally and has also received many awards worldwide. He's a recipient of several grants, including from the NIH, and has authored over 100 publications, many books, and is also the senior editor of Principles and Practice of Sleep Medicine, 8th edition. And Dr. Thomas has held leadership position in many national societies and has served on many editorial boards. It took a really long time to go through his CV, so this is just a summary of what I could. So thank you so much for being with us, Dr. Thomas. And without further delay, I would like to hand it over to you to share your expertise and and start the debate on precision targeting of sleep disordered breathing beyond classic central apnea.
I was not sure you're talking about me, but thank you anyway. So you can hear me, right? Okay. So I've been itching to give this talk for a little while. It's about central apnea, well, central forms of apnea, which means bad breathing coming from breathing control in some form or the other. And really wanting to go beyond the idea of a CAHI or a CAI and think of sleep itself as a composite, which has many interacting network systems and subsystems, all of which can cause instabilities. And they all impinge on breathing. Of course, breathing impinges on the same systems. So ultimately, you have sort of integrated set of instabilities, which may not be easily captured by our conventional view of things. So I'm guilty as charged here. Of the slides today, it's a very small set, which includes a little bit of data on the cardiopulmonary coupling system. But much of today's talk is not related. I always acknowledge my patients. I have to give them a lot of credit for allowing me to convince them to try less common therapies. Sometimes they would ask me, "Are you experimenting on me?" And I would honestly tell them, I don't know whether I'm experimenting on you. But certainly what we're trying is based on sound scientific logic. Of course, the funding agencies and my fellows and nurse practitioners and people who I interact with, like Andre, one of my favorites. Okay. So how do you figure out causality or disease drivers? There are different ways one can go about it. So you may have definitions. Sometimes a field has these definitions from legacy effects. And you can then do research to see if it predicts bad outcomes. So you have the NSRR, the National Sleep Research Resource, and you have the studies there which have standard staging and scoring and some outcome data. And you can see if any of the standard stages predict outcomes. But those standard stages were derived from opinions, not so much science, but people charting the unknown seas and trying to come up with some basic maps. But that's an example of forward prediction. And another example would be hyperglycemia to nephropathy. You can generally predict after seeing a certain number of diabetics who have high sugar and bad kidneys that, well, maybe high sugar does predict nephropathy. In sleep, your classic central sleep apnea, there's some data that it increases the risk of atrial fibrillation. So that would be an example of sort of a forward prediction. You can then have an outcome-based prediction where there are no definitions to start, but you throw data science at the problem. Genome-wide association studies, when they started, was a bit of that, where you just had a whole bunch of disorders and you had a jivas and you just, it was a fishing expedition, no doubt, but it was a good fishing expedition. Now you have somewhat more targeted approaches where you have, say, deep learning, whether it is PSD signals or MRI as an example, and try to predict Parkinson's or Alzheimer's disease. So it turns out you can do actually outcome-based sleep staging. And one of my collaborators, he's not on the call today, is doing this. So where we work backwards, we start with the outcomes and see what features of sleep predict those, independent of stages. And it turns out there are more stages than what we have now. And some stages are coalesced and some are broken down. That's all I'll say about this approach because it's all stealth mode right now. Then, of course, therapy-based prediction. A certain therapy benefits a certain range of pathologies, providing new insights. And the best example I could think of on short order was a BRAF V600E mutation, first described in melanoma. I think at least it first got famous in melanoma. And you have, of course, targeted therapy. But now the same mutant is there in colorectal carcinoma, papillary thyroid, hairy cell leukemia, Langerhans cell histiocytosis, and all of these will respond to the targeted therapies. Now with sleep, what happened there? Oh, something strange. Anyway, with sleep, you can still see my screen, right?
Yep.
Okay. So CPAP. So let's say we didn't know anything about sleep apnea, but we had CPAP. And you had a person complaining of insomnia, and you gave them CPAP, and the insomnia went away. Of course, we don't do that, but that would give us some new insights as to what could be causing insomnia. Or you couldn't really measure breathing, but you could measure oxygenation. And you applied CPAP, and the intermittent oxygen fluctuations went away. That gives you some insight. Similarly, I gained a lot of insight backwards by using dead space along with CPAP. I realized that the patterns of sleep apnea which respond to that manipulation far exceed conventional central sleep apnea, and gave a lot of insights, part of which I will share with you. So now we think of stability and instability. I'm going to go beyond just breathing. Of course, breathing interacts with sleep and the motor system and autonomic, and they all interact with each other, of course. So I'll talk about each of these in turn and how they can modify what we see as centrally driven disease. And the simplest definition for centrally driven disease is that if you prop up the airway, you don't fix the problem. That is, you support the upper airway, but you have not solved the problem, meaning there is a driver outside the upper airway which is causing the abnormal breathing. So there are many measurements of sleep quality, and we'll go through some of these. Okay. So here we have, this is a audience. I don't need to tell you, about stages and such, but in general, you will agree that these three samples largely have decent sleep. You have REM, non-REM, you have cycles. You do have bad breathing. On the top left, you have REM dominant apnea, same REM dominant apnea in the bottom. And in the top right, you have non-REM apnea. And then this is titration. It's hard to know. Well, I don't know here what REM was before, but this is successful titration. You have REM rebound, non-REM rebound. So this is open the airway and things are going to be okay. But now we have trouble in paradise. So here we have largely non-REM dominant apnea with terrible sleep fragmentation. The glue of sleep is gone. There is no glue. And you're not going to fix this person by holding the upper airway as open as you wish. You can hold the upper airway in as stable a way you want. This person is not going to be solved. You will improve oxygenation by ventilating the person, sure, but breathing and sleep will not be normal. So this is an example of a situation where breathing instabilities will be driven by fragmented sleep. And often there is high loop gain associated, but you don't need high loop gain to have centrally driven breathing instabilities driven by fragmented sleep. One other example of this scenario is epileptic discharges causing central sleep apnea. I didn't have enough time today to show examples of everything, but there are publications where you see epileptic discharge and then you see breathing disorders, sometimes central, sometimes obstructive. So that instability is driven centrally. So now you start getting the idea of what I mean by central instabilities, not just what you may score with your hand as central sleep apnea. Cyclic alternating pattern is EEG instability pattern, and all of us have periods of instability and periods of stability. When we are healthy, we spend more time in stable state. When we are sick and sleep is sick, we spend more time in unstable state. And you recognize the unstable version of non-REM sleep, it's on the left side, by these phasic complexes alternating with a low amplitude baseline. And this keeps cycling, basically. In truth, everything cycles. Blood pressure cycles, PLM cycle, respiration cycles, tidal volume cycles, sympathetic nerve discharge will cycle. But it starts with the EEG. And then you have periods where there is quiescence. There is, non-cap. So it turns out if you have a condition where cap is excessive, actually you will have sleep apnea. I have some data which I haven't published, but I guess I should. Done in 2004, almost 20 years ago, where I was really looking at sleep fragmentation effects on cognition. So I put headphones on and healthy volunteers who were screened with a prior sleep study. And then I had a program written in Adobe Audition, creating sounds, different sounds, and you play them and cause arousals. So it's auditory sleep fragmentation. So these are patients who were totally screened for sleep apnea on a PSG. Now with sleep fragmentation, I could actually induce sleep apnea. So when you have either a low arousal threshold or you have fragmented sleep, it makes your breathing wobble and it look like sleep apnea. So that's a centrally driven instability. Similarly, if you have a low arousal threshold or fragmented sleep from any cause, pain as an example, it will make your breathing unstable. That's a centrally driven instability. If you have tremendous periodic limb movements, it can create CAP, unstable sleep, nonstop. So on top here, you have large amounts of time spent in cyclic alternating pattern. This non-CAP is stable. So much of the time you're spending in this unstable state from periodic limb movements. And down here is a sleepwalker with fibromyalgia showing even in N3, you actually have these phasic complexes and CAP. But breathing here is only mildly unstable. But whatever instability of breathing here is driven by this top-down effect. Okay. How can we understand this a little bit better? So this is an EEG spectrogram. you have occipital, central, frontal. Red means strong power and blue means low power. And the frequencies are on the vertical axis. So when you're sleeping, you have strong power in the slow frequencies ebbing and flowing through. And on the left is the 60-odd-year-old, somewhat normalish person, generally good brain. Yeah, here you have your spindling activity. Not good, okay? I don't need to go into the details of what this is for you to recognize that this is not good. This is the alpha band, a slow alpha, tremendous slow alpha, and very poor delta. Show you another example. On the top left is a fairly normal EEG spectrogram, rising and falling slow wave, and you have clean differentiation of various frequencies. So when slow wave energy goes up, the faster stuff goes away. Well, guess what here? Slow wave goes up, the faster stuff does not go away. So this is alpha delta sleep. Down here, you have alpha delta sleep. You have tremendous alpha activity throughout the night. Here you have delta and alpha coexisting unhappily ever after throughout. So patients who are in the lower panel, they will have unstable breathing, whether you like it or not, because their sleep is unstable and fragmented. This is another example of a centrally driven instability. And when you look at the actual respiration, it can look, by conventional criteria, it may look somewhat central, it may look somewhat obstructive, it may be ataxic. All of these can occur. So then we come to the effect of this kind of EEG instability, lack of adequate glue. And if I can just remind you, arousal intensity is not just an on and off. This is data from Magdi Yunus publications, and you can quantify arousal intensity starting with 1 all the way to 9. 9 is a nasty arousal. It's a big punch to the brain, and 1 is just oops. Similarly, you can look at the odds ratio product, which is a continuous measure of EEG depth. Here, after this, after the, where's my cursor, very right. Here you have a brief arousal and quick return to sleep. And on the bottom, you have a very slow return to continuous sleep. It's like you punch a person and they bounce right back up. Here you punch and they're out for the count. But what's the consequence of that? Here we go. The top left panel. This is the consequence of poor glue of sleep. I call it AWSTI, amplified wake sleep transitional instability. It is exactly what it says. It is amplified. It is wake sleep transitional instability. No one can argue that this breathing looks particularly bad. Yet on top here, there's a lot of N1, wake. And if it, I'll show you another sample soon. If it's all scored as wake, text won't score these respiratory events. And you totally miss incredibly important pathology. There's other examples of amplified wake sleep transitional instability. Here you have N1, N2, back and forth, and you have tremendous instability. And here you have 2 wake, 1, 2 wake, 1. And a person can spend 40 minutes, 30 minutes, even an hour in this state, especially if they have heart failure, traumatic brain injury, atrial fibrillation, neurodegenerations of various kinds, severe PTSD, these all kinds of situations where you can have this amplified wake sleep transitional instability. And guess what? If you throw CPAP at these people, they're going to thank you for it, right? Wrong. They're going to hate you for it. They're going to rip the mask off. They're going to have amplification of their central disease. And this central, you can argue, where does it come from? From the throat, from the brain? It's from the brain. Another example of amplified wake sleep transitional instability. On the top left is a person with Parkinson's disease. And breathing is just wobbling around and sleep is wobbling. If sleep wobbles, breathing will wobble. If breathing wobbles, sleep may or may not wobble. Clearly, you know that there are patients with sleep apnea who have really good sleep, really good hypnograms. But if you have really bad sleep, you will not have, it is impossible to have pristine breathing. I hope I make my case on this. All right. A quick word on the odds ratio product. Most of you hopefully have at least heard of it. and some of you hopefully have at least read it, but it's Magda Yunus genius, developed sort of with a labor of love kind of scoring of depths of sleep. And every 3 seconds, you have a number. If you have a 0, it means you're not likely to wake up or have an arousal in the next 30 seconds. If you're 2.5, it means you're toasted. You're going to be up. And it gives you a continuous measure of sleep. You can average it per 30 seconds, or you can just have it every 3. But the point to make here is that what is scored as a certain stage, N2 or N3, you can actually have different odds ratio product numbers. So as an example, on the panel where my cursor is, this is all N2, but the ORP is 0.38 all the way to 1.69, and it's clearly sleep is deeper when your ORP is lower, right? Because you have a lesser odds of waking up or having an arousal. But now we throw that at a hypnogram for analysis. On top, you have a person who spends most of their time in N2. And I've always taught this: N1, N2 N1, N2, N3 were not made by God; they were made by man, and man, of course, is flawed. Man, women, persons, and N3 is a completely made-up thing. It has some utility, thankfully, but it is completely made up. So anyway, here you have lots of N2, and look at this beautiful, nice sleep depth flying across the night. Slow wave power would actually co-vary with this, so will theta density. Now here you have another one with a lot of N2, but this is garbage sleep. This sleep is not happy. You can see that the ORP is much closer towards wakefulness, even though technically you have, a lot of N2. So those who have fragmentable sleep, they're at tremendous risk of unstable breathing. And you hear about how arousal threshold amplifies sleep apnea, etc. It's the same thing, basically. You don't have a low arousal threshold if you have great sleep. It's all a matter of how you may choose to look at it. Okay. So now the motor system. The motor system must be feeling fairly lonely. By the ASM guidelines, the only thing you need to care about is if the motor system in non-REM sleep, no relevance, forget about it, doesn't matter. In REM sleep, it helps you figure out whether a person is in REM or not, REM without atonia. That's about it. But there is a tremendous amount of information in the motor system, both in the chin and in the appendicular system. And you have restless sleep disorder in children. You have restless sleep disorder in adults too, which, by the way, will respond to intravenous iron, but that's a different discussion. So now the chin EMG, I'm sure all of you look at it, and you don't know anything much about it. But in non-REM sleep, it is one of the best markers of quality of sleep. And a person like the one on the top left, you can see how the chin tone is clearly sculpting the badness of sleep. And here, breathing also has some instabilities. This is a titration. And it goes back and forth. They enhance each other's instabilities. So part of this breathing instability is a centrally driven instability because sleep is abnormal, and this motor system abnormality is probably driving it. Why do I say probably? I don't have conclusive proof, but there are patients, many, many patients now, who, when they have this kind of severe motor instabilities, and often they have periodic limb movements too, I treat them with intravenous iron dextran, and that actually solves their problem. The next time I give a talk, perhaps that's what I will show. Anyway, the one down here, you can see how the motor system is very, very clearly very pathological, and the activation of the motor system far exceeds the activation of the EEG. Important driver here is the motor system. It is so close to, well, forget close. It is always at a firing threshold So you have constant activation of the motor system. So here, the breathing instability is driven in part by a pathologically active motor system. And now we can try to figure out what are some features of motor driving system of respiratory instabilities or system instabilities. Here you have periodic limb movements, lots of them. Here you have polymorphic periodic limb movements. Periodic, but they don't follow the nice little rule. And this complex has multiple subcomplexes. This is a polymorphic. So you see this polymorphism. You see them here too. Some movements are quite different from the others. So this is a feature of a pathologically activated motor system. So how do I recognize a pathologically activated motor system? PLMs while awake. PLMs across the whole night, even in REM sleep. PLMs associated with amplified wake sleep transitional instability. Unstable breathing co-varying with PLMs. Bad limb movements, bad breathing. Movements are quiet, breathing is quiet. Now you can ask, which one follows the other? Fair question. Treat with IV iron, get them back to the lab. No PLMs, breathing normal. Case closed. Unstable breathing co-varying with, oh, sorry. Looks like I say, oh yeah. Unstable sleep co-varying with PLMs. Same idea. Short interval PLMs. There's actually a paper from Raphael Ferry in sleep in the last couple of years. So you have intervals less than 10 seconds. And guess what? Text won't score it because it's not within the rules. If you haven't figured out by now, I'm a strict no ASM rule zone. Polymorphic PLMs. Now here I'm going to show you some examples of badness driven by PLMs. On top you have somewhat more conventional, you have periodic limb movements, but you do have respiratory instabilities. These are probably just interacting with each other. Hard to be sure that one is a driver, but they clearly are interacting because they're time synchronized. Now down here you have short interval PLMs and you have cyclic alternating pattern. This is extensive epilepsy montage. And there aren't epileptic spikes, so I have to make a case that the periodic motor activation, the pathologically activated motor system, is driving the unstable EEG. And now things get interesting. You look at this one here. These are definitely PLMs in terms of timing, but look at the individual morphology here. These are clusters of activation. And now I'm blowing this up here on the left. See how there is this reverberation back and forth of pathological breathing oscillations and pathological motor activation. You may be tempted not to score these because, oh, it doesn't fulfill the rule. Wrong. These are severely pathological motor activations, and you will not solve your breathing problem by just targeting breathing. So here the motor system is contributing to a centrally driven respiratory instability. Now we have, as you know, I'm fairly aggressive treating high loop gain sleep apnea. Estazolamide, these days adding Buspar, body positioning, supplemental oxygen, sometimes low-dose clonidine, non-vented mask, adaptive ventilation, whatnot. But we have patients who still have unstable waveforms. They also have periodic limb movements. We target the periodic limb movements, the waveforms normalize. Now, I haven't done this as a randomized clinical trial, so you can statistically challenge me and tell me that, well, those abnormal waveforms which have been present for the last 6 months and which have now disappeared after intravenous iron, I don't really have proof. And I agree, I don't have proof. Hopefully, next year in 2024, I'll be able to actually do a small pilot trial of intravenous iron in non-restless legs pathological motor activation and look at the impact on sleep physiology, including breathing. But until then, I don't have conclusive proof. So I hope I convinced you that you can have instabilities of sleep driving unstable breathing. And that unstable breathing, of course, may have a central look, may have a mixed look, may have a bit of an obstructive look, and so on. But now we come to public enemy number one, the carotid body. I'm almost 100% sure that there has never been a question on the sleep boards ever. This includes the ASM boards or the ASDA boards. I come from the time when it was the American Sleep Disorders Association. There's never, ever been a question on the carotid body. And the carotid body is our most important organ for a lot of downstream effects of sleep apnea and intermittent hypoxia. Sympathetic activation, hypertension, periodic breathing, metabolic dysfunction, all largely driven by the carotid body. And of course, the carotid body is important enough that oxygen sensing got Nobel Prize, but apparently not important enough to be on the sleep medicine boards. Let's change that. Hopefully, the next edition of Principles and Practice of Sleep Medicine will have a chapter on the carotid body. Maybe a thin chapter, but at least a chapter. Nevertheless, all of you know that the carotid body senses O2, also CO2, potassium. And without the carotid body, there is no periodic breathing. So, strong chemoreflex influences on sleep breathing are heavily underestimated. There is no way you can slice and dice the ASM scoring manual to accurately estimate when the chemoreflex is driving respiratory abnormality. And all the criteria like, 5, 50%, it's just made up stuff. There are, of course, different ways to detect high loop gain. And when you start estimating high loop gain, you realize that conventional classic central sleep apnea is a tiny minority of breathing control driven sleep apnea. So you can detect high loop gain by the conventional central apnea periodic breathing index. The ASM rules don't work. Completely obsolete. Sorry. Flow limitation is commonly seen in high loop gain sleep apnea, which is probably the correct term, although it's a bit of a mouthful. And snoring can occur. So you can't use the two key exclusion criteria of the ASM to recognize when breathing control is a driver, the primary driver of the breathing instability. High loop gain sleep apnea, probably a better term. It brings everything together. But high loop gain sleep apnea may be latent, triggered, or natively expressed. Native expression is when you have overt central sleep apnea. Triggered is when you have an arousal and you have a post-arousal central and lots of it, or bilevel. Latent is when you bring it out by anti-obstructive therapies of various kinds. Treatment emergent central sleep apnea is, of course, not a real disease. It's a consequence of the disease. TEXA or TECSA is just a reflection of poor treatment of sleep apnea. It's not the disease, it's the outcome. But why bother? What if there is high loop gain? I guess about 95% of the sleep community in the world believes that throw CPAP at people, it's going to be fine. It doesn't matter what the breathing looks like, you're going to be fine. And there's about 5% who disagree, and hopefully that'll become 6 at least after this talk. But why bother? Because it triggers instability. Insomnia is commonly seen. In fact, most patients with high loop gain sleep apnea have COMISA, comorbid insomnia with sleep apnea. There's reduced adherence and residual apnea. This is pretty much proven by now. Persistent symptoms. And the blood pressure response to CPAP, there's a nice paper from Chris Smickel, which is a secondary analysis of the heartbeat trial, showing that when CPAP, when there's high loop gain, CPAP improves the blood pressure response more. And that kind of makes sense. How do you detect it? There are many methods, of course. You can perturbed stable non-REM sleep. You have Andrew's original dial-down method. You have MACD's original proportional assist ventilation. We have Dempsey's use bi-level to lower CO2 method. You can do a readout of unstable non-REM sleep. You have breath-by-breath phenotyping. You have the conventional scoring. You have visual inspection and description, which is subjective, of course. Non-REM versus REM dominance. Non-REM dominant apnea is high loop gain apnea, although body position effects are also there. You can have oscillatory mapping. You can have mathematical analysis, as Scotty Sands has so elegantly done. And you can try to slice and dice somewhat the ASM guidelines. So here's a guideline from 2013 where it starts with a hypopnea. So now we're talking about hypopnea. And the first step they make is a fatal mistake right away, flattening. If there's any flow limitation, it goes to obstructive. That's simply not true. There's ample data showing that is not true. But nevertheless, the rest actually are pretty good. That if you have a sharp termination of the respiratory event, that's obstructive. If you have crescendo termination, that's central. Start of ventilation, the arousal occurs at the start of ventilation. The arousal occurs at the maximum of ventilation, usually in the middle of the cluster. That's central. REM versus non-REM. So other points are good, but the flattening part doesn't work. And this is a graphical description of the prior methods. You have Dempsey's bi-level method, Andrew's drop-down, MACD-Eunice proportional assist ventilation, but there's not enough time to actually go through it. But just be aware that these things are around there, and there's pretty good data there. And then you have elegant mathematical endotyping by Scotty. And they have 4 traits, but there are more than 4 traits, by the way. An obvious 5th trait is sleep fragmentation and amplified wake sleep transitional instability. But nevertheless, all of you are hopefully aware of these 4 traits. They don't explain everything, but they certainly allow you to more precisely targeted therapy if you're willing to accept the fact that OSA, what you call OSA, is not just all upper airway. There are numerous other phenotypes, gender, stage dominance, cluster analysis. You can be big, you can have high BMI, high hypoxia with low AHI. I'm making this up sort of as an example. And you can have REM dominant, thin person, REM dominant, big person, and so on. So you can, if you have large enough numbers and expose the numbers to cluster analysis or machine learning, you can certainly come up with some logical stuff. You have those who kick a lot. In fact, the best data that periodic limb movements are problematic is from our very own Andrei Zinchuk. Read his paper and pay attention to PLMs. If you don't know what to do PLMs, ask me, I'll tell you. If you want to get more insights, PubMed, you use these keywords: Zinchuk A sleep, Thomas RJ sleep, Sands A sleep. You will get plenty of data on endotyping, phenotyping, and how to go about that business. I'm good for time, it seems. Okay, so this is Scotty Sands' work, mathematical endotyping. Again, I'm not going to describe his method, but just point out that on the left is a person who does not have high loop gain, and on the right is a person who does have high loop gain. Ignore the math for now, but just look at the actual graphs. See how these events are evenly spaced and they look like each other. This is called self-similarity. This is arousal threshold endotyping. Basically, if you have long events and it takes your estimated ventilatory drive to be really high before you wake up, you have a low arousal threshold. If you wake up too easily, you have a high arousal threshold, pardon me. While if you wake up too easily, you have a low arousal threshold. So this is a method which I've helped developing, assessing self-similarity, meaning does one breathing complex look like the next and the next and the next? It's essentially an envelope mapping. So 0 self-similarity, 33%, 56%, 74%. So let me show you what it actually looks like. Or before that, elegant work from Ankit with David Rappaport's group, where you basically, in real time, running, quantify how much a given sequence is obstructive versus central. So you have a obstruction versus central probability as a running metric, not trying to make the whole study as OSA versus CSA. And you'll find these features all make sense. Stuff like crescendo pattern of airflow. Flow limitation, well, they make that mistake again, but nevertheless, the rest of it actually works. Symmetric desaturation, what I call band-like oxygen desaturation versus asymmetric desaturation. Okay, so here's now trouble in paradise. You apply CPAP, you have bad centrals, okay? What's the standard? Oh, send the patient home with it. It's going to go away. Guess what? It hasn't gone away. And the visual thinking, of course, you're not going to get this when a person has overt high loop gain apnea. Now things get a bit more complicated. On the top, you have basically OSA. But look at the events. They're so self-similar. Timing is even. They all are obstructive events. But look at the self-similarity. Apply CPAP, the self-similarity persists. Next example. On top, you have some long cycle obstructions in REM, but that same person in non-REM sleep has these short, about 28-second cycles of obstructive events, self-similar. This person has no chance of responding to CPAP or anything which targets the upper airway primarily. On top left, you have profound non-REM sleep breathing instability. Some of these you will score as obstruction. Some of these you will score as central. Some of these you will not know what to score them as. No worries. Same person goes in REM sleep. Guess what? Perfect stability, practically. This is centrally driven instability. This is high loop gain obstructive sleep apnea. It's also self-similar. Your conventional scoring fails you completely. Opiates cause a disintegrative pattern. But on top left, you have ataxic breathing. How do you score this exactly? It's very hard to score ataxic breathing. Same person goes to REM sleep, great stability. Another example of centrally driven respiratory instabilities. More centrally driven instabilities in opiates. Persistent instability on home CPAP. Persistent instability on CPAP. The same person at home. When sleep is stable, you have classic ataxic breathing. When sleep is unstable, you have mayhem. What do you call this? Well, it's slow breathing. There's bradypnea. The poor algorithm is flailing and tagging some things this, tagging some things that. Based on opioids. So on top you have, this is a mistake, wrong. All right. Oh, sorry, this is correct. This is the same person. On one part of the night, you have reasonable stability, although there's some jiggling there. Other part of the night, you have great instability. It's stable versus unstable non-REM sleep change, as well as possibly body position change. The same person now gets on to bi-level. Full disclosure, I did not treat this person until later. This is data from the online systems. And you can see there's substantial bi-level related instability. Then a person is put on Philips ASV, wide open. And you can see tremendous instability. There's centrals, distorted breathing, patient ventilator desynchrony. And now I add dead space and narrow the range, and you have better breathing. There is still slow breathing enough that the backup rate kicks in, but there's greater stability of breathing and probably sleep. So this gives an example of opiate-related central instability. And of course, the algorithms of the PAP devices cannot pick up short cycle periodic breathing. Now here, this is wobbly breathing. Here, this wobbly breathing. They don't exactly follow your classic rules, but these are all short cycle, high loop gain, residual respiratory events on PAP. And let's see how we do for time. I'm good. So now we have the problem of underventilation and overventilation. So this is a person with amyotrophic lateral sclerosis who is on Bilevel 12/4 and is getting overventilated. 9/6 is getting underventilated. Breathing rate is more than 40 times. This is 6-minute lines, more than 40 times a minute. So that is, a centrally driven instability. BBAB, before baclofen, after baclofen. This is a person who has very mild periodic breathing, barely detected by the Philips software. The person is given baclofen for sleep-related priapism. Yep, it's a thing. And baclofen is the best treatment. And we induce drug-induced instability, central sleep apnea, periodic breathing. You can recognize these patterns in a home sleep study. So here you have self-similar respiratory events. Even the pleth is self-similar. And this is what the band-like oxygen desaturation of high loop gain, centrally driven instabilities look like. So that's actually REM out there, V-shaped desaturation. So these are two examples of self-similarity mathematical analysis. They were scored with a CAHI of 0 on the home testing by conventional scoring. And what you're seeing here is the respiratory effort signal, and the turquoise tags are basically the self-similar areas. So you have marked high loop gain features, but conventional scoring says, nope, nothing at all. Adaptive ventilation. Recognizing instabilities on adaptive ventilation can be a challenge, but you have to look at the pressure outflow. When you see pressure cycling associated with disrupted sleep, that's ASV-induced respiratory instability. You can see the same thing here. The C-press signal is the pressure output of the device. It goes up, goes down, goes up, goes down. So does sleep go up and down, up and down, up and down. What does it look like at home? On the right, you have a decently working ASV with some degree of cycling of pressures. On the left, you have a completely failing ASV with massive pressure fluctuations. And in both cases, the device detects nothing. More ASV instabilities, pressure cycling, distortion of respiration, slowing of respiration. In fact, if a person's respiration slows on the adaptive ventilator, that's a patient fighting the ventilator. On top, you have CPAP, non-vented mask. Things are going reasonably. We switch to ASV, and there's immediate respiratory mayhem. Everything goes wrong. There's central, slow breathing, distorted breathing. The patient is gasping, choking, fighting the ventilator. Best of luck trying to score this by conventional methods. CO2. By using CO2 modulation, I have learned what are the patterns which can respond to that approach, and what then suggests the various patterns which can exist driven by centrally mediated instabilities. So on top is the CO2 device data. And you have pre-CO2, post-CO2, pre-CO2, post-CO2, using just 0.5 to 0.6% CO2 with CPAP, with PAP. Now, then we converted that idea to dead space, and we have a non-vented mask, entitled CO2. An example, so this is the original patient 0, before dead space, after dead space. Heart failure, pre-dead space, post-dead space. And if you look at the heart failure patient, you would score these as obstruction, right? Because there's clear flow limitation, there's snoring, all that. Wrong. These patterns actually respond very well to stabilizing CO2. On the left, you have just hypnograms, CPAP, failure, ASV, failure, non-vented mask and CPAP, success. There's a split night, fail, ASV, fail, non-vented mask, success. Pandemic times, no lab for almost, no titration for almost 6 months, no lab for almost 4 months. No problem. Person with high loop gain apnea, Reluctantly, I put the person on CPAP, telling them, you're going to have trouble. And trouble they did have. And guess what? The device is detecting all of these as obstructive apneas. I add empiric non-vented mask and 50 cc dead space, market improvement, but not completely solved. Added acetazolamide, solved. This person refuses to come to the lab for a proper titration, says, I'm doing fine. So during the pandemic, I treated almost 100 patients this way. No lab needed. So these days, on home study, if there's overt high loop gain, I do not start them on CPAP alone, either acetazolamide or non-vented mask. Oxygen, long history of use. Give an example of how well oxygen can work. Here's a person with mixed physiology apnea. On the left, on the diagnostic study, didn't reach central apnea criteria. The person was willing to buy oxygen, and we have now markedly improved sleep and oxygenation. The person also has multiple sclerosis. CPAP refractory titration on top. We add dead space, things look a little bit better. We add oxygen, and things are stabilized. Though it'd be hard pressed to score these as classic simple. Acetazolamide, I use a lot of it. This is patient 0 on CPAP and dead space, ongoing instabilities. Added acetazolamide in the middle of the night, solved. Another example, before acetazolamide, overt, severe, non-stop periodic breathing with somewhat shorter cycles. After acetazolamide, much improved, but still there is periodic breathing. It's not like acetazolamide is the answer to everybody. It improves things. How we use sedatives? Very straightforward. You got to recognize fragile sleep. Probably, I'm happy to share these slides, of course. Probably leave that to the discussion. And this is phrenic nerve stimulation. I'm sure you've seen these slides. Different people have shown this. This is courtesy the company. It unfortunately doesn't always work that way. So here's an example of phrenic nerve stimulation failing in a person who had failed CPAP, failed bilevel, failed ASV, et cetera, et cetera, et cetera. And then with the phrenic stimulation, there was greater stability, but clearly we had obstructive sleep apnea. We added CPAP, and basically things are solved. And last sequence here, hypoglossal nerve stimulation. Recognizing instabilities on hypoglossal nerve stimulation is really challenging, but once you get a hang of it, it's not too bad. So this is a good story, pre-stimulation, post-stimulation, okay? Nicely working, that's your stimulation artifact. But now you have failing hypoglossal nerve stimulation with ongoing respiratory events. Some are central, some are obstructive, some are kind of periodic, they are short cycles. Added acetazolamide, stability. Vagal nerve stimulation. In non-REM sleep, you have these respiratory events. So that's your vagal stimulation artifact, where the arrows are. REM sleep, there is clearly improvement, but the stimulation still induces instabilities. So this is a centrally driven provoked instability, a neurostimulation provoked instability. Now the same person, for reference, that's your non-REM sleep. Here, CPAP and non-vented mask, solved. So even in vagal nerve stimulation-driven instability, CO2 is important. And I will tell you that it always doesn't work as well as this. This is just a nice example. Eric Heckman has a real monster of a patient where the vagal nerve stimulation is really the cause of the instabilities. And it's really hard to fix. I think I should probably stop there. But just to show you that sleep quality, you can have apnea with very poor sleep quality. The top mountain range is stable breathing through cardiopulmonary coupling. And you can have apnea and really good sleep quality. So those who have poor quality are at greater risk of, again, centrally mediated instabilities in a broader sense. And here is your approach to sleep disorder breathing. You need to take care of everything in the given patient. A certain patient may not need everything, but you have to find the right balance between mechanics, control, and sleep. And if you notice the sleep apnea treatment guidelines have nothing to say about control or nothing to say about sleep. Definitely nothing to say about sleep. And that is the end and thank you for listening to my raving and ranting.
Thank you so much for this fantastic, thought-provoking, very innovative talk, Dr. Thomas. I don't see any questions. Please feel free to put in questions or ask them yourself. I had a question. So for these centrally induced instability patients, I guess the treatment depends on what's provoking that. Especially the ones that we commonly see, the ones with low arousal threshold, would they benefit from a non-vented mask along with treatment of insomnia? And also, what would be your suggestions for places that don't use non-vented mask yet? Like what's needed and how do they start?
I mean, estazolamide and sedative, actually, it's a pretty good cocktail. I have several patients with actually central sleep apnea, overt central sleep apnea, using 125 milligrams of estazolamide, side sleep, and zolpidem or Lunesta. And they're getting, you know, it's been better than using PAP. Estazolamide doesn't work for everybody because it may not reduce loop gain enough.
Right.
I tend to use small doses, trying to just avoid or to minimize their, renal stones and diuresis and so on. I don't go more than 250 milligrams. I suspect if I went higher, I could probably, make it work better. But stabilizing CO2 is key, and it's just very easy to do. Adding oxygen, I used to hesitate offering patients oxygen if they didn't qualify, in the conventional way. But I realized that patients are quite willing to pay for oxygen if it makes them feel better. So now I'm more regularly discussing oxygen, doing a trial of oxygen, and quite about 30% of patients say, I'm really sleeping better with that, and I'll pay $75 a month for rental, or I'll just buy the concentrator. Sedatives can really be used quite safely in non-REM dominant apnea. I mean, anything which glues sleep a bit better, just make things better. And I have a small number of patients, I can count on one hand, who I'm treating the periodic breathing just with a sedative. That's it, nothing else. So it's really making sleep stable and resilient to minimize the high loop gain effects. So, if you mix and match and personalize the care a bit and just ignore all the ASM guidelines, you'll be fine.
And what dose sedatives usually and when you
So
start the
zolpidem 5, 2.5 to 5. If a woman, I start with 2.5, male 5. Lunesta usually 1 milligram. I've more recently been trying to use the orexin antagonist, and it's most useful when sleep is very fragile and fragmented. And often the older individuals where I don't want to use a GABA-based drug. It's been hard to get, there's this program, Quivivik 360 for daridorexant. But patients who are on Medicare and such, often they're the worst sleep. They can't avail of these, other options. So trazodone I don't use. It just causes too much hangover and it doesn't enhance stability of sleep. Benzodiazepines work great, but they come with all their baggage. I'm sort of suffering a little bit from my freely prescribing benzodiazepines in the 90s and early 2000s, before the zolpidem era, for patients with high loop gain apnea. Now I have to get some of them off it because they're having cognitive impairment, Alzheimer's or otherwise. And I've done okay with combining either low dose Remeron with an orexin antagonist, or Ramelteon with an orexin antagonist. Not quite the same. And a few patients have decided, you know what? I like my sleep. I'm going to keep doing it.
Got it. Thank you. Anyone has any questions, please feel free
Dr.
to
Thomas, I'm interested in the pathologic motor activation causing the respiratory instability, but how do you account for the situation where there is no evidence of motor activity when a patient has sleep apnea, and then on the same study in maybe a split night or maybe a follow-up study. You put them on CPAP, the sleep apnea disappears, and then you start to see the periodic limb movements. How does that explain?
So my best explanation for that is that the motor system is hyperactive in these patients. It was sub-threshold until CPAP was applied. And the application of CPAP is somehow biologically uncomfortable enough, even if it's making breathing much better, that it's enabling triggering of periodic limb movements. I have not actually seen too many of those. If you're willing to score PLMs regardless of respiratory events, but it is true, there's a subset of patients who are totally quiet, not a twitch on the diagnostic study when they're gasping and choking, and when you apply CPAP, lo and behold, you have. So they are a little mysterious, and I don't have a great explanation for them. But I whack them with IV iron, and they respond. So the system is basically closer towards firing threshold than otherwise. There are, of course, many patients who don't twitch their limbs at all, regardless of the apnea. So their firing threshold is higher.
Thank you.
Great. Any other questions anybody has? I don't see anything in the chat room. If anyone has any questions, please feel free to unmute yourself and ask Dr. Thomas.
I send a PDF of my slides. Feel free to, anyone wants them. There's nothing, no secrets in there.
Yeah, and this will be available too in 2 weeks or so that everyone can see it. All right, so I think that's it. Thank you so much, everyone, for joining, and thank you so much, Dr. Thomas. This was really excellent and very thought-provoking. So I'm sure everybody has their mind going with this now. Thank you again, and see you all next week. Bye-bye.
Thank you.